some people may think of one of the famous genocide issues. Well, it has been there, it's part of our history, but that one is something we are advancing with. Now it's time for a Rwanda that we think we should thrive for, a country we should dream for, where we were not born to kill each other, we are not born to be poor out, so we can do better things. Rwanda has been evolving in everything for the last 20, 25 years. That is really amazing. It's really amazing.
First of all, Dr. Quinn is here. This is her third time here, but she comes for short visits and hopefully longer as time goes on. She's a urogynecologist, just recently took her board, so board certified in urogynecology now. So please welcome them and be kind to them as you always do.
She was admitted here 15 days ago. We are thinking maybe she's having a fistula. So we need to examine to see if it is fistula, if it's coming from the vagina or where it's originating from.
Yeah, let's empty her bladder, I think. Yeah. So she's holding quite a bit in her bladder, actually.
I'm surprised.
So it's a little, that's the thing, it's a little hole.
Yeah.
So this has a good chance of closing on itself. So urogynecology is a combination of gynecology and urology. I look at pelvic floor disorders in women, so kind of ranges from urinary incontinence, pelvic organ prolapse, fistulas, fecal incontinence, kind of anything affecting quality of life in the pelvic floor.
She came the first time. I was still in training. I was still specializing. I was doing my final year. So she was doing Ilogyne, and we're having a lot of cases. We're having a lot of cases, women with urinary prolapse and really complication requiring Ilogyne. There are things that we could do, but we also needed someone like her, like a specialist in that, because there are things she introduced, and which helped to improve in the management of the patient we had.
My main goal is really to teach attendings and residents procedures that I think are safe for them to be able to do, because ultimately, I'm there 10 days and I can help a finite number of women during that time, but if I can train people to do these procedures, then they can really be helping women all the time. So I'm gonna check. Okay, when I take this up to the sacrospinous, it's totally reduced. See how she doesn't have any, so I don't really need to do anything but this procedure. So we won't be able to do a neovagina for her. That's a huge surgery. But what we need to work on, but I'd like to see her, is to get dilators for her, because that's really the first step even in the US. Most people don't need a surgery. You use dilators and you gradually dilate that space.
We are actually not only the teaching hospital, but the referral hospital. Difficult cases or the oncology cases, these are the things that are referred to our hospital, and we use it to teaching the most difficult case to our student and resident.
From specifically a urogynecologic standpoint, I think I just see patients that have been living with something for years, and having complete prolapse and working in the fields for 8 hours a day, and they've been doing this for 10 years and haven't been able to get any help for this issue. So That's a major thing. Our women with fistulas that have been leaking for years and really don't have any, have just kind of had to deal with it. And how long ago did she deliver her baby?
umwana wanyu mumubyaye uriya mwana wamubyaye hashize igihe kinini
imyaka 3 zuzura mu kwa karindwi
around 2 years and a half.
2.5. And when did she start noticing this bulge? 1 month ago. Okay.
Ihangane turikoraho.
She really doesn't have a cystocele. Do you see how my finger
I
is
know,
there?
it's just-
The front wall of the vagina is pretty well supported, and it's really just the top coming down here. I'm gonna check the back. The same is true at the back. Push down hard as you can.
Sunika,
Push, push, push. Yeah.
push, sunika.
Yeah. So it's really, she has a little cystocele, but it's really uterine. Yeah. I've noticed here there are actually young women who seem to have fairly advanced uterine prolapse. So this patient was a 28-year-old, had only had one child, but had pretty significant uterine prolapse. So her uterus was coming about this far outside of the vagina. She was very bothered by this prolapse, and honestly it would potentially harm her chances at future fertility to have the prolapse so far out. I'm only here this week, so can we get her programmed this week? Tomorrow? Wednesday?
Kubaza ejo. On her side she's ready, so
Okay.
on our side.
So let's see, yeah, so
But I think it can.
if we can program her? Okay.
ujya kubagwa se wumvaga bimeze wumvaga wishimye
njye nagiye kubagwa mfite ubwoba nari nzi ko ndagwa ku iseta naratitiraga abaganga bakampumuriza ngo nimpumure nuko bantera ikinya bambaga ndi kumva nta kibazo usibye ko nari ndi kumva bari gukora mu nda ariko sinari ndi kubabara yabanteye ikinya cyo mu mugongo cyica uruhande rumwe ubwo rero ngiye kubona mbona amavuye amahoro.
Yes.
So you all have not done this procedure, right?
Yes.
No. So I'll do this one so I can show you what to do, but I'll let you place a stitch and close it up, but I want to show you the depth of dissection and all that. Sound okay?
Yes.
Okay. Feel that, and that gives me an idea where I'm going. So why don't you feel that? So we did a hysteropexy, which just means lifting the uterus up to a ligament within the pelvis, a strong ligament in the pelvis, but not removing the uterus. So, so she can potentially have children in the future while also correcting her prolapse. That case went really smoothly. The nice thing about that case is it's done totally through the vagina. There's very little blood loss often, and the recovery is pretty easy for the patient. And the risk of infection, and certainly serious infection, damage to any organs is really minimized because you're not inside the abdomen at all. It's all just done through the vagina. So my hope is that every time I come, a few more people will be doing vaginal surgeries instead of large abdominal incisions.
wumvaga wishimye se umaze kubagwa nyuma
Nyamara kubagwa numvishe ari byiza nishimye kwa yuko nari ngize kandi n'ubu ndi kumva nishimye muri njye nari nihebye nzi yuko ntazakira ariko ubu ndi kumva nishimye gusa Imana izakomeze bahe ubushobozi bakomeze bavure n'abandi muri njye ubu ndi kumva byandenze.
So if I look 5 to 10 years down the road for GSC, I'm very optimistic. First and foremost, I hope that we continue to expand our services in the countries that we are. We have done a tremendous job of establishing the infrastructure, bringing surgical teams down there, delivering surgeries and following them, but I think there's a lot of room for expansion within these countries. I think that there are surgeries outside of the field of urology and urogynecology that can be offered. I have inquiries very routinely from other types of surgeons and medical specialists who would like to join in our trips, which we haven't done yet. And my hope is that with time the charity can grow, we can obtain more resources, both financially and equipment and collaboratively, and expand in these ways.
If we continue the same way, we have students, teachers, and starting subspecialties, I believe that in about 10 years, Rwanda may have sufficient or enough medical staff, teaching staff, educators, so that we can have a better result with the education system. There are a lot to be done. There's still a lot of things to be done in terms of equipment, in terms of planning very well. But if we continue the same way and we have a good collaboration with partners, I'm sure we'll be able to have a better future for our patients.